I think we'll wait just one more minute before we officially get started. Okay, I think we will get started. Good evening, everybody. My name is Dawn Park. I am a co-chair of the Education Committee for SOPE. I am a cardiac sonographer at Nationwide Children's Hospital. Tonight, we are very excited to host our first session for Fellow Boot Camp. But first, we want to give a big thank you to all of our institutional sponsors. We have Seattle Children's, Lucille Packard Children's Hospital, Stanford, Nemours Children's Hospital, Cincinnati Children's Hospital, Kentucky Healthcare, Kentucky Children's Hospital, Lurie Children's Hospital, and Rady Children's Hospital. If anybody has any questions, the email is on the slide if they want to become an institutional sponsor as well. We really appreciate all of their sponsorship for SOPE. Next slide. So tonight we are doing part 1 of 2 for boot camp for our fellows. We are really excited to host this every year for all of our new incoming fellows, but also for our other fellows that are still continuing their categorical fellowship. Next slide. We wanted to give you guys a heads up. So we will be having Fellow Boot Camp Part 2, segmentation review by Dr. Talgeva. This is going to be August 13th. So normally we meet on the 4th Tuesday of the month, but next month we wanted to have it a little bit sooner and a little bit closer to this Boot Camp Part 1. And so we are going to be hosting that on August 13th, Tuesday, August 13th at 8 o'clock as well. Next slide. So just format and rules. So normally our speed sessions are 45 minutes, but we're actually going to go for about an hour tonight. We have 3 really great presentations that we're looking forward to as well. So we'll go for about an hour, as well as part 2 will go for about an hour as well. You are muted upon entry. We want participation. You can raise your hand and unmute if you are called upon. Another way to get your questions in so that you don't forget them is to just put them in the chat. Our moderators will ask those questions. We're going to do a couple questions in between each session and then a final Q&A at the end. Next slide. Sorry, we're going to go back a slide. So let me introduce our 2 moderators for tonight. We have Dr. Ray Lorenzoni. He is a cardiologist with Connecticut Children's, and then Dr. Shannon Neese. She is at Nemours Children's Hospital. So those are our moderators for tonight, and I look forward to our talks.
Thanks, Dawn. So I think we're going to get started with Dr. Elena Kwan. So Dr. Elena Kwan is the Director of Pediatric and Fetal Echocardiography at the Children's Hospital of Montefiore in New York. She's a clinical assistant professor of pediatrics at the Albert Einstein College of Medicine, and her clinical interests include fetal, transthoracic, and transesophageal echocardiography, as well as 3D echo and knobology. So Dr. Kwan, if you want to get us started, that'd be great.
Okay. Okay. Can you hear me? Okay. All right. Thank you for inviting me to participate in this speed session tonight. I'm going to be talking about introduction to pediatric echo. So the main things we're going to be covering are reviewing the planes of a normal pediatric echo, and I'll also indicate where the probe indicator position is for each view, and I'll discuss the different structures that you see in each plane as we go through it, but I'm not going to go over Doppler M-mode quantification and advanced analysis. So just to show you with this ultrasound probe here, when I refer to the probe position, probe indicator position, this area here that often has a darker color, or it's either recessed or it's got an area that's raised, that groove area is going to be the notch that I refer to. And you should always hold the probe like a pencil and try to anchor yourself as much as possible. So these are the papers that have been published from the American Society of Echo, and the most recent one from February of this year is highlighted in yellow, and it has the updated guidelines for performing a pediatric transthoracic echo. So most of the talk and the contents of it is from that. All right, so in the first view, it's the subcostal, or some refer to as subxiphoid coronal sinus view. And so depending on your institution, it may be that you have the sector down here where you're looking up at the liver versus looking down at the liver, as in this image here where it's inverted with the sector on top. And so using this one here, the IVC can be seen in cross-section as well as the descending aorta. And this is going to, the IVC is usually slightly anterior to the descending aorta. And you can also see the liver is on the right side and the stomach would be on the left side. And in an instance like this, where you see the IVC is posterior to the aorta, then you have to be concerned that there may be an interrupted IVC and that this is a dilated azygos. And in this image, you also see that the liver is actually on the left side and that the stomach, the contents, is on the right side of the patient. And that's a patient with a heterotaxy and abdominal situs inversus. So this is with the probe at notch at 3 o'clock. And at that same area, you're going to have your hand over the probe and coming from sweeping from posterior anteriorly. And this shows you how you're going to be able to see the heart lying on its side, and then the LV outflow tract and the RV outflow tract as you come anteriorly. And you'll also be able to see the septum as well. So in this 2D image here, you see the IVC and the aorta here, and then you can see the hepatic veins draining into the right atrium. Here's the atrial septum, the RA, LA, and then we see the LV outflow tract and the RV outflow tract coming anteriorly here. And then with color, you can see that there is a little bit of acceleration of flow at the area of the patent foraminal valley. We can evaluate for any insufficiency of the AV valves and for any LV outflow tract or RV outflow tract obstruction, which there is none. And then also with the color box here, we can see that there are no ventricular septal defects because we're able to map the septum. Orthogonal to that view at 90 degrees from there at 6 o'clock, we're going to be able to see the subcostal sagittal short axis view. And that's going to be where, as you go from right to left, you'll see the bicaval view here, and then be able to see the outflow tracts again, and as well as the septum. And so in this view here, you can see the SVC, that you saw the atrial septum, and then we can see the mitral valve en face, the LV and the RV outflow tracts. We can also see the function of both ventricles. And then in the color sweep, we can also rule out that there's no VSDs here, and that there's no outflow tract obstruction. To look at the IVC, you can either get it from the abdominal ultrasound way, where they have the probe indicator at 12 o'clock or 1 o'clock. So from that initial situs view at 3 o'clock, you go counterclockwise to 12 or 1 o'clock, and then you angle anteriorly to be able to see this IVC lengthwise. And you can also see the hepatic vein coming into it here with and see everything entering into the right atrium. Or at the inverted view, where you have the indicator at 6 o'clock, you can see the SVC, IVC here standing more up and down, and this is another way to be able to see it. And if you aren't seeing a connection of the IVC, then in this instance here, as you're angling towards the aorta, the abdominal aorta, you can see that there is a prominent venous flow behind the aorta, which is the dilated azygos. So then, sorry. Okay. The subcostal sagittal abdominal aortic view is going to be where you can either get it at 12 o'clock to 1 o'clock. So from that other view of the IVC, now you're going to go a little bit more posteriorly to get the aorta opened up lengthwise, and you can evaluate the pulsatility of the aorta by 2D and the color flow by as well. And then you can Doppler it, or in the view with the notch at 6 o'clock, you can get it standing up and down like this, and it's a good angle of interrogation for Dopplering it. The subcostal right anterior oblique view, this is going to be with the notch at 2 o'clock. So you're going to go counterclockwise and then have the heel of your hand down to angle anteriorly, and you'll be able to evaluate the inflow and outflow of the RV. You'll also be able to see the conal septum here, and this is particularly important in tetralogy of Fallot, where you can see the anterior deviation of the conal septum and the infundibular hypoplasia, as well as the VSD. The subcostal left anterior oblique view, or the LAO view, this is going to be with the indicator at 5 o'clock, and it's also called an in-between view for the atrial septum, as you can see in this image here. But you can also see the AV valves on FOSS at this angle, and so you can see the mitral valve and rule out any cleft, and see the anterior and posterior leaflet, and the tricuspid valve. You can see the septal anterior and posterior leaflets here. And if you have a patient with an AV canal, you can see the common AV valve on FOSS from this view. So then going to the apical four-chamber, you're going to have the patient on their left side with the left arm up and have the probe indicator at 3 o'clock and go laterally at the apex. And in this view, you can evaluate the AV valves and the outflow tracts again as well, as and also see the function. And so here, as we see, we're going to be able to, sometimes you'll actually be able to even, you'll be able to even see the IVC as a circle as you're going down, and see it coming into the right atrium when you're dipping down into the liver. And then as you come up, you'll see the coronary sinus, and then the AV valves at the crux, the LV outflow tract, and the RV outflow tract. And in this view, you'll be able to see how the AV valves are offset and see the attachments of the AV valves to the free wall for the mitral valve, and having septal attachments for the tricuspid valve. And the color view, we can evaluate for any VSDs and for any AV valve insufficiency or any stenosis of the semilunar valves. Sometimes you might also be able to see one pulmonary vein from each side. As you go more medially in the patient's chest, you can get the RV focused view, where you're able to bring in more of that RV free wall. And in this view, you'll be able to see the RV size and systolic function a little better. And then as you go either clockwise to 5 o'clock or counterclockwise to 11 o'clock, depending on which way your institution has the aorta pointing. At 5 o'clock, you're going to get it looking like this, with the aorta here, LA, and the LV here. And for 11 o'clock, the aorta will be pointing towards the right of the screen. And you'll be able to see the mitral to aortic valve fibrous continuity and look for any left ventricular outflow tract obstruction and the function as well. And then going more clockwise to 6 o'clock, we'll be able to get the two-chamber, where we get the appendage on the left side of the screen. And this will be anterior. So this will be your anterior wall and your posterior wall of the LV. When looking at function, you can also assess the size of the left atrium. If you have the notch at 12 o'clock for this view, then it'll be with the appendage on the right side of the screen. Peristernal long axis is going to be with the indicator at 10 o'clock. And so the probe position is going to be midway along the left sternum, with it pointing towards the right shoulder of the patient. And we can evaluate, again, the different valves and function. And so in this image here, we can see the starting point of this clip shows the aortic valve and the mitral valve in the middle of the sector. We can see if there's any mitral valve prolapse, if there's any doming or thickening of that aortic valve, any subaortic membrane, and we can look at the function as well as the pulmonary valve if it looks like it's abnormal appearing. And the color sweep here, we can look at the integrity of the different valves, as well as mapping the septum as you move the color box over across the septum. So 90 degrees orthogonal to that. And if you start off from that view with the aorta and mitral valve and go 90 degrees, you should be able to get the peristernal short axis, which is with the indicator around 2 o'clock. And with this, you'll see the aortic valve morphology, mitral valve morphology, and evaluate the septum as well as function again. And so in this clip here, we can see it starts off with the aortic valve on FOSS, and goes out towards the apex. And in looking at that with color, we can map the membranous septum, inlet septum, then the muscular septum and apical muscular septum in this sweep. And we're looking at the function as well. We can look if there's a cleft in the mitral valve in this view, as well as assess the function of the RV and the size of the RV and compared to the LV. The coronaries can also be seen in this view. When you see the aortic valve on FOSS, you should be able to get by 2D in color the left main and the bifurcation into the LAD and circumflex, as well as the right coronary from the right coronary cusp. This sometimes you need to go a little bit higher up in the chest to get that to come in. Then as you slide up, you can go to the infraclavicular high parasternal view where you can get the SVC and the aorta in cross-section and the pants view of the PAs. So this is going to be where you don't see the pulmonary valve and you'll get just the branch pulmonary arteries. And it's a great place to measure them or Doppler them. And then here we can see them by color. It's also called the Gumby view by some people. And then the importance of this is that as you go posterior to that, you should be able to get the crab view, or at least be able to look at the pulmonary veins from each side. As you focus in on each branch PA horizontally and go behind it, you should be able to get the upper and lower pulmonary veins. Just be careful that you don't confuse the left upper with the left atrial appendage. And sometimes you may see 3 on the right side because you may get the middle vein as well. And then as we go counterclockwise to 12 to 1 o'clock, you can get the high left parasternal sagittal ductal view, and you want to focus on getting the LPA to be opened up length like this long, and the aorta, and not open up the RPA. The RPA should stay a circle or just kind of end blindly. And as you sweep from the LPA to the aorta, if you see a third vessel in between, then that would be the ductus. If the vessel you're seeing is after it, then it's likely an AP collateral. But this is the way that you prevent confusing it with the RPAs by making sure you don't open it up in this view. So then we go to 3 o'clock and have the patient's neck extended and go into the suprasternal notch to look at the suprasternal short axis view. And so we're going to start off by having the view where we see the innominate vein entering into the SVC here. And the aorta is going to be in cross-section and the RPA should be opened up beneath it like this. And then you go from here superiorly to open up the branching of the head and neck vessels. And so you see the circle become either 2 circles, or you see sometimes the innominate artery and then the bifurcation. And so here we can see the innominate artery in red with the right subclavian and carotid, and then you'll often see the 2 color flow circles of the left carotid and subclavian in a left aortic arch with normal branching pattern. And then also as you slide over towards the left side of this innominate vein, you can rule out if there's a left SVC coming down from it or not. And then when we go to 1 o'clock or 12 o'clock, you can look at the aortic arch and open it up like a candy cane here. And you want to be able to show that the brachiocephalics are coming off of it so that we know that it's not a duct that you're showing. And we can evaluate the pulsatility of it, look for measuring the transverse or the aortic isthmus, and then look at the flow along the arch and the proximal descending aorta. And then the last view is the high right parasternal view. This is going to be with the patient in the right lateral decubitus with the right arm up and the probe indicator at 12 o'clock. You're going to position the probe on the right of the sternum and look for the SVC and the IVC with the atrial septum here. And so this will be your right atrium, left atrium, and you should get the cross section of the right upper pulmonary vein and the right pulmonary artery here. And so the wall between the right upper pulmonary vein and the SVC, this is going to be your sinus venosus septum. So this is a great view to be able to rule out a sinus venosus defect. And then as you angle towards the aorta, it's a great angle of interrogation to be able to Doppler for the LV outflow tract. So in conclusion, the pediatric transthoracic echocardiogram provides a comprehensive evaluation of the heart with standardized views, and thoughtful scanning is important in each view. Consistent practice will allow for familiarity with normal anatomy so that you can recognize when there's something that's not normal. Thank you.
Thank you so much, Dr. Kwan. That was
Yeah.
awesome. We have time for 1 or 2 questions if there are any. And while we're doing that, Dr. Satzer, if you'd like to pull up your slides, welcome to.
Yeah, while we're waiting for questions to pop up in the chat, or if you want to raise your hand, that's fine. I had a question, Dr. Kwan. Oftentimes I remember as a fellow that, I'd be told that patient positioning is often one of the more important things to really bring the heart to where you want it to go, or to open up a window. Any tips for the trainees and for the younger members who are imaging about how to optimize some of those views?
Yeah, I definitely recommend for the subxiphoid views that if you have an older patient, if you have them bend their knees up, then that will bring the heart closer to the probe. And then with even babies, I always, even if they start off looking like they're calm, always swaddle them so they can't move, and try not to touch the patient directly with your hand, and use the blanket to kind of be in between, because it keeps them from getting upset as much. And even though they're a baby, I still turn them onto their left side for the apical and peristernal views, and I still really arch them well to get the aortic arch. So really getting all the same movements with and moving, and even the right peristernal view. Sometimes I get lazy and don't want to move them onto their right side, but it really does help to just move the lung artifact out of the way.
And there was a question, any tips for hyperaeration of the lung to see more of the heart structures?
Yeah, I mean, moving them from side to side to try to get it out of the way is probably the only thing to really do, because sometimes you just can't get around it. And then the subxiphoid views should technically be not affected by that. And so many times, especially if it's a baby, that's going to be your only view that you can get, and you can usually get most of the information from that view.
Then it looks like there was one more question, which says, I found it tricky to get a reliable assessment of the RV function. Which views do you find most useful in evaluating the right ventricle?
So I like to use the peristernal short axis, where you can really see the circumferential shortening of the RV.
Awesome. All right, we'll move on to the next talk. So Dr. Michael Satzer is an attending physician in the Department of Pediatric Cardiology at Lurie Children's Hospital of Chicago, and he's a clinical assistant professor of pediatrics at Northwestern University Feinberg School of Medicine. His clinical interests include fetal cardiology, pediatric echocardiography, and artificial intelligence in congenital and pediatric cardiology. And he was also my senior fellow, so I learned about echo from him. So go ahead, Mike.
Thank you, Shannon, and thank you to the SOPE Education Committee. I'll just note that there's a thunderstorm here in Chicago, so I apologize for any rumbling in the background while I'm talking. I have no disclosures, although I do have some pictures of specific ultrasound probes that don't endorse any of the particular companies, just to give you some examples of what we're looking at. So echophysics, why do we care? So options, we can use our advanced knowledge of the underlying principles of ultrasound to optimize clinical diagnostic accuracy. We can help to pass certification tests for our sonographers and fellows and cardiologists. We could potentially beat Dr. Wyman Lai at Echo Trivia, or maybe all of the above. So hopefully this presentation will help with some or all of those things. So sound is, of course, the propagation of pressure waves through a substance. And sound has various properties, including amplitude or loudness, as well as frequency, or the rate at which pressure waves oscillate, which is, of course, given in hertz or cycles per second. So ultrasound, by definition, is a sound that exceeds the ability of the human ear to detect, so over 20,000 hertz. However, ultrasound probes generally make sound in the megahertz range, or millions of hertz. Different frequencies do not behave the same, and significantly higher frequencies are more often reflected from surfaces, which is good, but they are also more easily absorbed as well. Ultrasound devices work by listening for reflected sounds that are sent out, similar to what bats and dolphins do. Ultrasound probes use piezoelectric material that have a relationship between charge and shape. So when a voltage difference is applied to the material, It changes in shape, and in doing so creates a pressure wave. And when this changing in shape occurs millions of times per second, it generates ultrasound. And then conversely, these crystals can also generate charge when pressure waves are applied to them. So in typical operating mode, ultrasound probes spend only a minority of time actively making sound, and most of the time actually listening. It's about 99.9% of the time. And plotted as pressure versus time, you can see that ultrasound probes generate pulses, which come in bursts. The time between these bursts is called pulse repetition period, which will become important later on in this discussion. There are different types of ultrasound probes. So on the left is a linear probe that emits ultrasound waves perpendicular to the probe and equally spaced. These are often used for vascular or musculoskeletal ultrasounds. A curvilinear probe, the second one here, has a wide contact with the patient, providing a wide field of view. And these are typically used for abdominal ultrasound and fetal echo, for example. And the most familiar probe, of course, is the sector probe or phased array, or just echo probe. And this has a small footprint that can be easily fit between the ribs, or see between the ribs. It also has a narrower field of view versus the curvilinear probe. And then typically all the crystals fire near simultaneously as well in these probes. So the probe name tells you the frequency range that can be emitted. So looking at this probe, for example, you know it's a sector probe from the S. And then 9-2 indicates that the range of possible frequencies is between 2 to 9 megahertz. Once a beam is emitted from a probe, there are multiple potential fates for that sound wave. So first of all, you can have reflection of sound. And this typically occurs at a change in medium. So for example, between tissue types. And pure reflection occurs at an angle equal to that at which it hits the surface, which is important. So as echo probes work by hearing reflection, the most signal from a 2D object will occur when it is perpendicular to the probe, also called the angle of interrogation. And that's why if you want to see especially a thin linear structure like a coronary artery or a valve leaflet, it's best to interrogate from a perpendicular angle. Another fate of a sound wave can be transmission. So even though there may be a change in medium, if those mediums are very similar in acoustic quality, then sound just continues to go. And then third, you can also have scattering, and that typically occurs with a non-homogeneous object, and that can lead to a grainy appearance of echo images. So we know that the speed of sound through various material, thank you physicists, is just over 1,500 meters per second, at least through soft tissue at body temperature. Ultrasound works by assuming that the distance calculated is proportional to time. So when a signal is received by the transducer, the distance from the probe is calculated as the time taken to traverse the object back to the probe divided by that assumed speed of sound. The intensity of the signal at any given location is then coded into grayscale, as in this picture down here. This is how M mode works. There's simply a single scan line repeated over time. And then when you plot those grayscale lines over an x-axis, you get a traditional M mode picture. 2D echo is a combination of hundreds of individual scan lines combined into a single image, which is then repeated to create a moving image. So basically taking M mode and forcing across this field of view. You can imagine that the maximum depth of interrogation defines the amount of time that it takes for the furthest object to be detected. So the equation in the upper right here shows the relationship between pulse repetition frequency, or basically how often the scan line can be repeated, and depth of the image. So an object at 10 centimeters will be able to be investigated 10 times less frequently than an object at 1 centimeter with a 1 centimeter depth. So this is the first trade-off that defines the practice of echo. The deeper the image, the less frequently scan lines can be sent and detected. And similarly, the more scan lines you have, or the wider the sector, the lower the frame rate. So echo image optimization is all about getting the most useful images while dealing with the trade-offs that are consequences of physics. So let's talk about the next trade-off in echo, which is resolution. A resolution is defined as the smallest measurable interval of an instrument. So in echo, there are 3 main types of resolution, and 2 of space, including axial and lateral resolution, and then 1 of time or temporal resolution. Axial resolution differentiates structures at different depths, or up and down, and lateral resolution differentiates structures at the same depth, or side to side. Temporal resolution, of course, differentiates structures across small units of time. So axial resolution is inversely related to pulse length, which in turn is directly related to wavelength. So higher frequencies with smaller wavelengths have better axial resolution. And so this is why we use higher frequency probes in babies, which produce often highly detailed images. And significantly, resolution of high frequency probes actually exceeds that of CT scans, getting down potentially to 0.25 millimeters versus typical CT of about 0.5 millimeters. The trade-off, of course, is that higher frequencies are attenuated quickly and cannot be used effectively for deep structures, such as with adult patients. Lateral resolution is inversely proportional to the pulse width. So the pulse width is narrower closer to the probe before these lines spread out. And additionally, using a focal zone can narrow the pulse width at a zone of interest. This is accomplished by the probe timing or steering the pulses that are emitted from the probe to intersect the scan lines at a particular depth. And we can actually set this on the cart, the echo cart. And in general, the focal zone should be placed at or just slightly beyond the area of interest. Lastly, temporal resolution is best with shallower maximal depth, a narrower field, using only one focal zone. And if you can actually increase the focal length, so you can use multiple focal zones, which essentially rescans the image for each focal zone. So having only one takes less time. And then using 2D without Doppler imaging increases your frame rate. And then also M mode, of course, that's essentially the highest frame rate, but of course, only linear imaging. So let's talk next briefly about ultrasound artifact, which are kind of like the gremlins of echo. Artifacts are real physical phenomena that nevertheless result in misleading picture. For example, ultrasound assumes that a signal is coming directly from the source of a reflection. So if there's a structure that has a very strong reflector, it may result in a reflected reflection. So bouncing off that strong reflector, seeing an object, bouncing back, then bouncing back to the probe. So on this right side image here, a parasternal long axis view, you can see mirroring of the myocardium here with the asterisks, and then also mirroring of the posterior and anterior leaflets of the mitral valve. So this is artifact, things that are not there, but just properties of the pericardium being a very strong reflector. Ultrasound also assumes that there's a consistent rate of sound being absorbed by tissue, or signal attenuation. So to prevent deep areas, or also known as the far field, from being too dark, these areas are brightened in a method called time gain compensation, or TGC. This can actually be modified by the sonographer on many echo carts. However, if there is material that absorbs more or less sound than expected, this results in falsely bright or dark areas behind it. So for example, on the image on the left, there is brightening behind the stomach because the fluid in the stomach does not attenuate the signal as much as the liver tissue around it. And this is called acoustic enhancement. However, on the other hand, very reflective objects like a mechanical mitral valve or the ribs or anything that has calcium in it can lead to acoustic shadowing behind it. All right, so the rest of the talk is on Doppler ultrasound. So basically, Doppler tells us how fast blood or tissue is moving. Doppler imaging works by the principle that any wave emitted or reflected by a moving object changes the frequency related to the velocity of the object. So when an object moves towards the probe, the frequency increases, that's reflected, and for an object moving away, the frequency decreases. So in Doppler assessment, instead of looking for the intensity of the return signal, the probe only looks at the frequency shift. So once the echo cart measures a shift in frequency, the velocity of flow can be calculated with the equation above. I share this equation most to show that there is an implicit assumption here. So the angle, or the Greek letter theta here, is assumed to be 0. The cosine of 0 is 1, so this term just falls out. However, if you measure flow at an angle that is greater than 0, you will underestimate the velocity. So in general, keeping the angle of inclination under 20 degrees from your object of interest is recommended, as the calculated value is about within 6% or so. So the type of Doppler imaging that I've shown so far is called continuous wave, or CW Doppler, as the probe both emits and receives sound simultaneously from different components of the transducer. The resultant image is termed spectral Doppler, so-called because it is presented as a spectrum of velocities across the vertical axis over time. There are, however, multiple forms of Doppler imaging. As continuous wave Doppler continuously sends out sound, the location of the return signal may originate anywhere along the single beam of inclination. So if you really want to know the velocity at a particular location, you must use pulse wave, or PW Doppler, which utilizes a technique called gating. So rather than sending out a continuous wave, discrete bursts or pulses of sound are sent out. The transducer then waits for the time at which it expects to hear back from that spot of interest, which is also called the sample box or sample volume, and then measures the frequency shift at that spot, essentially creating gates around the area and ignoring all of the other sound that returns. These pulses are repeated at a specific rate, which is called the pulse repetition frequency, or PRF. The limitation of PW is that physics caps the maximum velocity that can be detected. In a famous equation by the physicist and engineer Harry Nyquist, the maximum frequency shift detectable, or Nyquist limit, is found to be half the pulse repetition frequency. Any velocity that shifts the frequency more than this will result in an apparent reversal of direction, a phenomenon called aliasing, kind of like what happens with a camera that films a rotating tire that starts to rotate faster and makes it look like it's going backwards. So using all of the equations that we have seen today, we can calculate the maximum velocity that can be detected in any given situation. We can thus show that to avoid aliasing, we can try to decrease the depth, decrease the transducer frequency, so either changing probe or changing the frequency of which a given transducer is emitting, or move to CW Doppler if location information is non-critical. And this is just an example of a case of a patient who has a VSD, where interrogation is first done by PW, and you can see the aliasing here. It looks like it's going negative, when of course that doesn't make sense physiologically. But when CW is used, you can see that there's no limitation to the maximal frequency or velocity, frequency shift or velocity that can be measured. And you can estimate a better accuracy of the pressure difference between the two chambers. So now what do we do with these derived velocities? So echo does not measure pressure, but we can estimate pressure gradients. So in our last equation today, the Bernoulli relationship informs us of a relationship between pressure, velocity, fluid viscosity, and other physical phenomenon between 2 points in space. Fortunately, on a daily basis, we use a simplified version of this equation as we discount the less relevant components. However, it is important to note that the simplified equation will underestimate gradients in narrow vessels. So for example, surgical shunts or long segment stenosis. We can also assume the blood density, although with significant anemia, we may overestimate gradients, or conversely, those with polycythemia, we may underestimate gradients due to differences in blood viscosity. And then finally, there is a super simplified Bernoulli equation, where we neglect the proximal velocity, or V1. And so we end up with 4v squared, 4 velocity squared. However, if you have a proximal velocity that is over 1 meter per second, or if there are multiple areas of stenosis, then you have to take this into account. So for example, subtracting V1 if you have a higher velocity. So quick example, we interrogate a pulmonary valve, here using CW Doppler. We measure the maximal velocity on the spectral Doppler and obtain 3.4 meters per second. Using the super simplified Bernoulli equation, we calculate that the estimated pressure gradient is about 46 millimeters of mercury, consistent with moderate valvular stenosis. And similarly, you can measure the mean gradient by taking the average velocity and using the same equation. The last form of Doppler is color flow mapping, which essentially performs PW at locations across an entire subsector of the image. For each sample volume, a color is assigned by convention. Red to yellow is toward the probe, and then blue is away from the probe. Aliasing is still a phenomenon with color flow due to the same physical principles. It also shows as apparent reversal of flow as velocities exceed the Nyquist limit. So such as the yellow and red coloration near the arrow here in a patient who has mitral valve stenosis, where the velocity exceeds the Nyquist limit. So finally, when we add color mapping to our image, our temporal resolution is also affected by the size of the color box. So our frame rate will be affected by how narrow the color box is. So narrower is a better frame rate. Shorter color box also gives you a better frame rate. But of course, sometimes we need to trade off frame rate if we need to fully investigate blood flow of interest. All right, that is all I have. I do have practice questions if we have time at the end, but that is all that I have for now.
Thanks so much, Dr. Satzer. That was awesome. If we have one or two questions, we can take them. And meanwhile, Morella, if you'd like to get your slides loaded, that'd be great. Getting lots of claps. I don't see any questions at the moment. That was a very complex topic that was distilled down into a very digestible amount of information. It's awesome. So we can move on to the next one, and then if there are questions at the end, we can go back to them.
All right, wonderful. So my pleasure to introduce the next speaker, Morella Dugulescu. She will be, giving the kind of knobology, quote unquote, knobology lecture for us, so that in addition to knowing what we should be looking at, we need to know how to get there. And so this is a crucial element of our echocardiography experience. She is originally from Romania, Mirella. She moved to Texas 22 years ago and got her education and training in pediatric echocardiography in 2012. She's been working at the Children's Medical Center in Dallas since 2015. Is also certified in fetal echo and loves 3D echo for preoperative cases. Mirella, please take it away.
Thank you so much, everyone. Bear with me. It's my actually first presentation to such a wonderful crowd. I am used to train fellows one-on-one or small groups, but this is a different scale. So I do appreciate the opportunity you gave me to be part of this. And I also want to thank Dr. Keelan, who encouraged me to say yes to this challenge, because I'm a firm believer that pre-scanning considerations are as important as knowing the knobs on the ultrasound system. I will go over really quickly over some of them. And I will start with how important it is to ask a few questions before you go scanning. Ask who is the patient you're going to take care of. Ask why are you doing the echocardiogram, and how are you going to achieve it. You do have to make sure you have the proper equipment. In my early months of my career, it happened when I grabbed an ultrasound system and I had to go to assess coronaries on a patient with chest pain, but I didn't have a high frequency probe. So it was a little challenging to use a 4 or a 5 to show coronaries on a 6 years old or a 5 years old, and even more difficult to show flow into the coronaries. So very, very important to know what you're getting into. Make sure your equipment has everything it needs, so you will be set up for success. Warm gel and the warm baby blankets will take you a long way, especially with babies, infants, even toddlers. Swaddling babies, I personally swaddle babies up to 7-8 months of age. I semi-swaddle up to 18-20 months. And most of the times it works out. Age and weight of the patient also very, very important for probe selection. As mentioned before, patient positioning, if attainable, is also crucial when you start scanning. But before you go to do an echocardiogram, make sure you take time to familiarize yourself with the ultrasound system. At some point, we used to have 5 different systems in our hospitals. So some people would be more comfortable with, let's say, a GE system over a Siemens system or Philips.
Hey, Marilla, I just wanted to make sure, I just wanted to check, I noticed the slides aren't yet advancing. It's fine if this is an intro. I just wanted to make sure that we're not missing anything.
Okay, let's see. Yes, they are not. Are you seeing the slides? Oh,
We see the first slide. Oh, and it looks
sorry.
like it goes through quickly. But yeah, no worries.
Let's see. Seems like I cannot use the arrows.
Do you have a page up or a page down?
There you go. There you go. I do have it. It's just let's see. There we go.
All right.
Now
I'm a little ahead. Get a mentor. I'll try to see if I can keep up with the slides. Get a mentor to guide your echo practice and correct your knowledge and skill set. And I cannot stress enough how important hand support and bed adjustment are for a successful echocardiogram. Obviously, when you get to the patient's bedside, you need to know how to turn on the machine, right? But that's a simple thing, right? You also have to be familiar with how to pull out a echo order from the work list, and every system is different. That's why I didn't include images, because there are many, and we work one-on-one with our fellows as they start their training on the first year, and not just the first year. As you pull out the order, you have to know what information to type in and where, and how to acquire the faceplate, because it's very important for the reader to have that information when they start reading the images that you're sending. Once you're ready to scan, it's very important to know where what's the appropriate probe you need to start with. You may have to use different probes on the same scan. On some patients, depending on age and their how difficult the windows are, I would start sometimes with a 4 and switch to 6, 4 in the subcostals, and switch to 6 frequency probe for the parasternals. So it's really, really important to to know how you can achieve the best image quality by using the right probe first. Once you determine that, it's important to know to adjust your depth. I've seen people just putting the probe on the chest and get the first image that they could get. And most of the times it can get better than that. You have to remember there's more buttons than gain and depth on the machine, all right? Many times the gain button is overlooked. The images come across too bright or too dark, and important information can be missed. So make sure you don't waste space. Therefore, adjust depth. Make sure your images are not too dark or too bright. Therefore, adjust gain. In order to get the best image, make sure you survey the patient's chest or the patient's apical area or subxiphoid area. Do not stay married in one spot. The first image that you see may not be the best image that you can obtain, the most accurate information that you can provide to the reader. I always suggest the fellows to learn one set of views at a time. There's no need to be an overachiever, especially on your first rotation. Just today, I had one of them, and we worked on subcostals. It was his first day of scanning, and it worked in a wonderful way because the patient after patient, we were able to practice subcostal views and sweeps, and it helps to get a solid foundation and remember little tricks and secrets that will help you get through a scan, especially difficult scans. Don't be afraid once you're familiar with the standard views to try non-standard views. But when you do that, make sure you make notes on the screen. I like to let the reader know where my notch is, where I'm on the patient's chest when I'm off standard views. It helps them get a better understanding of what you are showing the reader. To the imaging, very, very important. And this is what you start with. And one of the doctors I work with, Dr. Ikemba, she always stresses how important it is to follow a pattern 2D, color, Doppler, 2D, color, Doppler. So we'll look a little bit into the imaging that is used to assess the anatomic and the motion of the heart structures. Once again, you have to choose the appropriate transducer and imaging frequency. You have to adjust the depth depending on what view you're trying to achieve. Adjusting depth, especially decreasing depth, will increase resolution and frame rate, therefore a better quality image quality. Don't forget to optimize gain, so know where your gain button is, and make sure you use the TGCs. It's often overlooked. What are the TGCs? It's a number of buttons aligned vertical on right side or left side, or somewhere on the deck of the ultrasound machine. And what it does, it controls the gain on horizontal sectors of the images. So each little button corresponds to a smaller horizontal sector of the image that you have. Sometimes you have brighter superior, inferior portion of the image that you're showing, but the middle of the image is very, very dark. So TGC is very helpful to adjust the gain and kind of balancing out the image. Watch your screen. Many people in the beginning struggle to get the images, and they believe it's the buttons, but it's actually because they are not watching the screen when they are surveying the patient's chest. And best images, many times I've seen best images obtained when not watching. I do have a habit of freezing the image, and I scroll back and I show the trainee how beautiful on-axis image they obtained when they focused on their hand. So yes, buttons are important, but also watching the screen while you are surveying the patient's chest.
I just want to give a kind of a 5 or 10-minute warning if we just to stay on track. Thank you.
Color Doppler is used to enhance, it's a use of enhanced form of Doppler technology to assess direction of blood flow. And it was already mentioned, so I won't spend too much time here. There's a special button knob designated for color Doppler. Nyquist is important, which is also called the scale button. You have to know what you're assessing so you can adjust it accordingly. For low flow, such as SVC flow or pulmonary vein flow, you have to lower the Nyquist to be able to see better color flow. Obviously, if you keep it low and you're starting to assess pulmonary valve, for example, it's going to look aliasing, and you will wonder, is there an obstruction there, when the problem is the Nyquist not being adjusted properly. So Nyquist is adjusted by the scale button on the ultrasound system. Also important to adjust the color box to the area of interest. So that would improve color resolution and frame rate. And again, will offer a better quality of the image. I have here example of a Doppler, a color Doppler. Here, the video doesn't want to work, but you see a very clear definition between blue and red. There's no aliasing, so that tells me that the scale was adjusted properly. It was already mentioned that the red represents the blood flowing towards the transducer. Blue is represented by the blood flowing away from the transducer. Okay, M mode was talked about. There's a button designated for M mode. I'm not sure on if this feature is available on other systems, but GE has an AMM feature, a button on the screen that allows you to adjust the angle of interrogation. Sometimes you get a really nice short axis of the LV, but when you're trying to do an M mode, it doesn't cut through where you would want it to. So little things that will make a huge difference when you assess LV function. I want to talk about a little bit about pulse wave and continuous wave Doppler. Doppler echocardiography is used to measure and assess blood flow through a heart valve or vessel. And there are two types of Doppler echocardiography, pulse wave and continuous wave. Pulse wave is used to sample blood flow into a specific region. We have a button designated for pulse wave and a different button designated for continuous wave. So for example, if you wanna assess different level of obstructions at the pulmonary valve level, subpulmonary, pulmonary, and supravalvular, pulse wave allows you to sample at specific points, while continuous wave is used to assess high flows along the Doppler line. So you would not know where the high velocity comes from exactly. Examples of pulse wave, tissue Doppler, and continuous wave here. So a few, just to recap really quick, know where your depth button is, gain, know how to make use of the TGC, make sure you know how to adjust the frequency, how to adjust the Nyquist or scale when you assess different structures. Make sure you know where the sector width button is, because it will help you sometimes increase the frame rate when you make the sector smaller, depending on the area of interrogation. I like to use the dynamic range a lot to get rid of the fuzz and make the images crispier. So that's the beginning course of knobology. Obviously, that's more to it, but it's a really good start to be familiar with.
All right, thank you so much. So we're just about out of time. But we do have a couple questions in the chat that we'll go through quickly. And if we could bring up just those last slides while we're getting these questions answered. So the last question for Dr. Satzer. It was mentioned that continuous wave Doppler can be used for assessing valve stenosis. Can also be used for assessing valve regurgitation.
Absolutely. Yeah, so you can assess multiple elements of regurgitation, the duration of regurgitation. You can use it to assess the peak velocity. Sometimes that can be helpful, especially tricuspid regurgitation. You can use it to assess even function sometimes, to estimate the change in pressure over change in time. So absolutely, and multiple uses for that.
All right, wonderful. And then no one specified here, so I'll just open it up to the group. The use of M mode, either parasternal long or parasternal short axis, how useful is it for assessing EF and why? And how does it compare to other calculations of EF?
I think that for the ejection fraction, it's more for the shortening fraction, but if the septum is dyskinetic or paradoxic, then you're not going to be able to use that. So we typically use the short axis of the LV and the apical four chamber to get the length, to get the 5/6 area length and get the ejection fraction that way.
And I have a question for Mirella. That was a really excellent talk and overview. when you're training new fellows who are just starting, how do you tell them to use the eye scan or auto functions for optimizing images? Do you recommend they start with that or try to optimize it first? What's your approach?
Well, we do start with an auto. We have actually on the machines the auto button on. We have presets, predetermined presets. I have my preferences obviously on our machines. I pay attention to the map, 2D map that I'm using. I pay attention to the frequency I'm starting with, and obviously depth. Actually, depth is the first thing that I adjust. And sector width.
Awesome.
All right, wonderful. I want to just remind everyone that Fellow Bootcamp Part 2, you know, the continuation of what has been an excellent boot camp so far. Please, if you've attended this and enjoyed it, please tell everyone about it, and hopefully we can have an even bigger audience. This one has already been amongst the most populous that we've had, so that's great. It will be August 13th, 2024, 5 p.m. Pacific time, 8 p.m. Eastern time, and we have a good contingent in Tokyo that comes on for us at 9 a.m. On the other side of the Pacific. And again, just want to thank our sponsors. Yeah, Dawn, any other final comments?
I just
No.
want to say
Miss
one more
anything?
thing.
Oh, yeah, go ahead, Jen.
Congratulations. If you're a new fellow starting, you're joining an awesome field, and we're very excited to have you.
I reiterate that too. I've been teaching fellows for a couple decades now, and I really enjoy working with the fellows. And I just appreciate all the time and effort our presenters put into these presentations. It's so helpful for this echo fundamentals that they really need repeated over and over again to learn all of it. Physics is not easy. Remembering our ergonomics and making sure they're scanning correctly. I had a fellow this week tell me, I never thought echo would make me go work out again. So it's kind of fun. So yeah, we'll see you guys August 13th. At Dr. Talgeva, and it's going to be great. So continue doing what you're doing a great job. We know fellowship is not easy, but we appreciate all the hard work you guys do for it. So everybody have a good night, and we'll see you August 13th.
Thank you, everyone.